Good evening, everybody. Welcome all of you to the second part of oral malignancies. In the first class, I think we covered the pre-malignant lesions, which are extremely important. And I'm very grateful for the continued guidance and moderation of Dr. Jyothsna, consultant head and neck oncologist and ENT surgeon. I think she brought out a lot of good practical points in recognition of the all the pre-malignant lesions and which pre-malignant lesions we need to be concerned about. So we'll proceed on to the clinical features and management of the oral malignancies. Over to you, Einass. Thank you, Jyotsna, again for your moderation. Thank you.
Sir, my pleasure, sir. We will continue with this, Einass.
Yes, ma'am. Previously we discussed about the risk factors of oral cavity cancer. Going to the clinical features, the clinical presentation will vary depending upon the site and the type of malignancy. However, like patients usually can be patients may be asymptomatic, or they might present with symptoms that of complaints of loosening of teeth, pain, or else presence of non-healing ulcers, and in addition they can also have symptoms of odynophagia, weight loss, and symptoms of referred autalgia. So rarely patients can. Yes,
Einass, I think more than dysphagia and odynophagia, which will be more features of the the throat malignancies in the throat region or in the vocal cord and pharynx and larynx and things like that. I think here there will be change of I think difficulty in closing the mouth and dribbling of saliva and also the change of intonation and voice. It is not so much of a change of voice, but their inability to speak certain words because the mouth doesn't close, the approximation doesn't happen. Jyotsna, am I right?
Yes, sir. Very true. So we can actually tell it as like restricted tongue movements, which can lead to slurring of the speech also.
Correct.
And also due to trismus also, they won't be able to spell few things correctly.
Correctly.
Yes.
I think dysphagia and odynophagia is more of pharyngolaryngeal tumors and obviously, of course, esophageal tumors.
Correct, sir. It can happen, but in a very later stage.
Later stage,
is
yes.
a T4 stage, yes.
Yeah,
T4
correct.
and all. They can finally present with the dysphagia and odynophagia.
Correct.
But commonly what they usually present to us is ulcer. That is the most common one. Then some sores, oral sores, and pain.
Yeah, painful oral ulcers, and I think inability to eat because it hurts a lot when the food comes in contact with the ulcer.
Correct, sir. And sometimes, for example, these tumors, they may present in a later stage who already have submucous fibrosis or the trismus associated with it. So, in few conditions, they will present with a lump in the neck. So it would have already progressed to the neck swelling, that is the nodal swelling. So in such cases, we'll have to do the thorough examination of the oral cavity and other parts of the head and neck to find out where the primary is. Again, that is a whole different topic, but these are all few commonly presenting symptoms. Mainly it is chronic ulcer and then pain while eating, as sir said. There can be bleeding from the gums too, sir. That is also very common.
Yeah, bleeding.
Yes.
So all of you, please note, I think Einass, you need to modify your presentation accordingly. Okay, carry on.
Yes, sir.
Yeah.
Yes, sir. Yes, sir. So they can present with these symptoms. In going to the diagnosis, clinical examination, the initial.
Einass, one second. We have seen about the clinical features. Now, as physicians or as the clinicians, we will be giving more importance to the history even before we jump to the evaluation, correct?
Yes, ma'am.
So our first evaluation starts from their history. So could you please enumerate on that? What all the questions you will be asking? Say a patient has come with ulcer in the throat, okay, in the buccal mucosa. What all things are going to ask?
Yes, first, ma'am, like any history of smoking, like betel nut chewing or like quid chewing,
No.
in
No. Einass, go
yes, sir.
methodically. First of all, when there is an ulcer, you have to take the
The
history of
duration,
when onset of
Correct.
was there any
answer,
pre-existing lesions that they had
lesion.
noted? What was the onset of the ulcer? How has it progressed? Is it rapid progression? Slow progression? Additional other symptoms associated with it? Then after the symptomatology, go to the risk factors. You can't jump from one thing to another. It has to be methodical. Otherwise, you will miss certain things.
Hmm. So patient has
Yes, sir.
come in front of you. You just imagine that he is there with an answer. So what all questions are you going to ask?
Let
Nothing.
us ask Vinod. Let us ask Vinod. Vinod, are you there, Vinod? When is his exams? Tomorrow or day
And
after?
yes, sir, tomorrow. I think he must be traveling, sir.
Tomorrow is exam.
Okay, right. He may not be there then.
Mm-hmm.
Okay, then Nikita or Praveen answer that question. Or if Samir wants to volunteer also, I'll be happy. Come on, quickly. We'll not waste time because there is a lot to discuss. What are the what is madam has asked a very simple question. It's not rocket science. What are the history questions that you are going to ask the patient who has come with an ulcer in the mouth? Very simple.
So we would ask about his habits, sir.
Again,
No,
again,
habits are
start
later.
from
I
what the
have just
patient
told
has
you, and you are
presented.
again going to. You have not listened to what I have just told you.
So Nikita, patient has come to you with an ulcer, like any part of the ulcer, like, what would you ask the patient? When did it start? How was the onset? Correct? So
Yes,
that
ma'am.
is what I'm trying to ask. So once you get an idea about since when the ulcer is, say for example, a patient has come to you with an ulcer for 10 days now, would you be asking or worried about many things? No, right? So it also depends on how long the duration of the lesion is important, correct? And
Yes,
how
ma'am.
it has progressed. Is it associated with any pain? Is it associated with any bleeding? Like such are the questions. So whatever clinical features now Einass has mentioned, along with that, you will be asking few negative histories as well, correct? You
Yes,
are
ma'am.
asking whether the patient had any habits or not. It will come to your personal history, correct? Habits
Yes.
history. So I'm telling, go like how a clinical case is presented. So how do you take the history? Can you come up with few questions to the patient?
Yes, ma'am. When did he notice it first?
Hmm.
And did it progress from that point to till now?
The size of it, correct? How do you, like, you would ask the patient, how do you feel like it has increased or not, like in their layman terms, correct? And then
Yes, ma'am.
what
Yes.
else would you ask?
Is it associated with any pain or bleeding, or is
Correct.
it causing any discomfort while having food?
Correct.
And any other area also he had similar thing, and which might have resolved by now, but any history of similar
Very good. Lesions
presence?
in the oral cavity, correct.
Yes. And
Any
any
otalgia?
recent? Yes, ma'am.
Tell me.
Associated factors like any surrounding areas have also onset of any symptoms.
So he won't be knowing the symptoms. So you will have to ask him leading questions. So what all would you ask? So for example, like, in the present chart, what she has told, like, any loosening of teeth is present just next to the lesion. You already mentioned any difficulty in swallowing would be there. As I and Ravi sir said, like, any restricted mouth opening, which is very important, correct? So these are all
Yes,
few
ma'am.
things which will you be asking. And finally, you'll also be asking about the weight loss also. Okay, so these are few questions.
Weight loss, loss of appetite, any neck swelling in the neck, has he noticed?
Neck lump, correct.
So all of these things. Then go for the personal history: smoking,
history.
alcohol, spicy food, sharp teeth. Syphilis, of course, is not there anymore. The five S's. What are
Any
the five S's? You know? Do you know, Praveen? What are the five S for associated with oral malignancies? Praveen?
SN.
Ah, Hello? You've gone
Sir.
blank. Huh? 5 S's associated with oral malignancy.
Smoking,
Smoking, correct?
spices, sharp teeth, sir.
I've already mentioned those.
Sir.
Then
Spirit, sir? Spirit?
Syphilis, spirits.
Yeah. Okay, 5 S's. Syphilis is probably not there now anymore because I think it's become quite rare, but it is also one of the pre-malignant lesions. Okay, I
Yes.
think I think what Dr. Jyotsna wants to know is, you have to go methodically. History will give you a lot of pointers. Never ignore the importance of history because majority of your clinical examination depends on what the history is suggestive of. Okay, so I think history is important, then clinical examination. Come to clinical examination, what are the things you're looking for?
First will be the inspection findings, wherein you will be inspecting the entire of the oral cavity, starting from the lips to the, you'll also see the cheek, the buccal side of the gum, and
What is the first thing you notice, ma? What is the first thing you notice?
The symmetry, sir.
No, not first
Oral
thing.
opening, sir.
Yeah,
How much is
first,
the patient
first thing
able
you
to
notice
open?
is there halitosis? Is there, what is the state of hygiene of the oral cavity? You have to comment on
Yes, sir.
that first. Because obviously if there is halitosis, then you know there is a problem. So halitosis, and as you said, then there's oral hygiene. Then as you said, whether the mouth opening is normal or is it restricted. Then you comment on the dentures, so if the teeth are there, what are the teeth looking like? Is there any loose teeth? Then you comment on the lesion per se. You have to then describe the lesion in detail, inspection. Then you have to do a bidigital or a gloved finger palpation of the lesion, and then you look for any other pre-malignant lesions in the oral cavity. Is it as Dr. Jyotsna keeps saying, is it a field change? Is there any are there, pre-malignant condition? And when there is pre-malignant condition, and is there a tumor that is developing in a already existent, either erythroplakia, leukoplakia, or lichen planus, anything like that. So look at all of those things, and then you have to look for and the mouth opening, as we said. Then look for lymph nodes, examination of the lymph nodes to see if there is any, and if this lesion is there, you have to then, whether it is mobile or is it, if it is on the tongue, is the tongue movement restricted, is the lesion infiltrating the base of the tongue or the base of the oral cavity, is it infiltrating the mandible? All of these things, yesterday we discussed all these things. So I think you should.
Yes, sir.
I have not come prepared for this class, but this is common sense. You have to rattle it out like this. In the exams, then the examiner will stop you and say, move on to the next thing. If you keep on dithering, then they will you will get stuck in this. Jyotsna, anything else you want to add? I just wanted to finish it because otherwise
Yes, sir.
it'll get delayed.
Delayed. Absolutely, sir. So you have covered most of the points, sir. Inspection, palpation, and definitely neck examination. Just to finish the examination, we also would like to do one indirect laryngoscopy because as a this one.
Yeah.
If required, clinical procedures like endoscopic procedures. But otherwise, yes, sir, you have already enumerated everything, sir.
Okay. Now go to the diagnosis and what you are going to do.
Yes, sir. So after clinical examination, there'll be the imaging studies. There are various modalities which are available. CT neck with a CT scan, that is CT neck with contrast, and CT chest can be done, which is the most commonly done preferred
Primary
imaging study.
modality, correct.
Yes. In the here you will look for any sort of anatomic distortion or any tumor enhancement, and here it will also help us in seeing in assessing the primary side for a contrast enhanced CT will help in determining where the primary site is. In addition, it will tell the extent of the tumor infiltration and whether also help in analyzing whether the mandible is any bony structures like the mandible is involved or not. And then the
Not just
furthermore,
mandible, not just mandible. You are also oral cavity, even maxilla can be involved.
in one.
So you have to talk about, in general, maxilla can also be involved, no? Upper, if
Yes,
it
sir.
is the upper palate. Yeah.
Yes, sir. Yes. In general, like bony involvement can also be assessed with the help of a CT scan. Furthermore, regional lymph node involvement can also be assessed with the help of a CT scan. And usually here, it is also sensitive in detecting the extracapsular spread. So you'll look at the size of the lymph nodes. Furthermore, the presence of necrosis, lots of fatty hilum, all of these these parameters will help in assessing the regional lymph node involvement.
Nikita, quickly enumerate the lymph node on ultrasound. What are the features which will suggest that it may be malignant? Quickly.
Yes, sir. Breadth greater than the length ratio, sir, and loss of
No. What are you didn't say it clearly. It is taller rather than
wider
wider.
than taller.
It is not wider. It is taller than wider.
Taller than wider.
Okay.
Loss of hilar continuity, sir.
Not called continuity. What is it called? Hilar? Anybody else? Nitya?
Loss of
fatty
hilum.
there is corticomedullary differentiation will not be there, sir.
Correct. Loss of corticomedullary differentiation. Okay. Then what else?
And loss of fatty hilum,
Vascularity.
then taller than wider.
Okay. That we have already said. Size of the node. Anything above 1 centimeter, it has to be suspicious. Size of the node. Is there matting, capsular invasion? If there is matting,
Calcifications.
calcification. So all of these features. On ultrasound, you can get a lot of information whether this is, just, reactive lymphadenitis or malignant. It may not be always, sensitive and specific, but it will at least, wake you up to the possibility that it may be malignant. Okay. Continue, Mark.
Yes, sir. The next modality is PET-CT, which can be used for further evaluation. It is especially helpful if the CT is giving an indeterminate finding, and it is useful in case of useful for finding any occult distant metastasis if present, or if there are any unknown primary lesions which are again present. Furthermore,
No,
yes, sir.
I think let us all be very clear. I think Jyotsna can correct me if I'm wrong. See, PET-CT is not a initial investigating modality. It is generally reserved if you are unsure as to the nature of the lesion, or if you, for example, if the patient is unfit for surgery and you want to see if there is any distant metastasis and things like that, then only PET-CT comes into this. I think PET-CT is not a initial, it is only useful in the follow-up after treatment rather than as a initial treatment investigating modality. MRI is much more, you should talk more about MRI, because in soft tissue lesions, I think MRI is, as Dr. Professor Gurushantapa said yesterday, tongue and any soft tissue differentiation and all these things are much better appreciated by MR scan rather than CT scan. Bony involvement is much better appreciated by the CT scan. So you have to use the combination of these MRI and CT as and when the situation warrants. If, for example, if the CT is unequivocally saying everything, then you don't have to use MR. If there is any doubt, only then use MR scan. If it is soft tissue lesion, you may want to use MR scan initially, and if it gives you all the information, you don't have to go for the CT. So it is using, this is what is clinical judgment. After you have taken the history and clinical examination, you can then tailor your investigations according to what you clinically come to a conclusion. Jyothsna, please.
Yes, sir. True, sir. What you said is right, sir. So I would just put in like a few points for the practical approach of it. Generally, you would go for contrast enhanced CT scan for most of the lesions.
Absolutely.
So you will see for where the site of the lesion is. So your clinical examination comes into picture for this, and also your history as well. If the person is having any lesion in the hard palate, but also he has like any numbing over the cheek, so I am suspecting any perineural invasion. So that time the MRI will come into picture. If it is just a plain ulcer or any lesion in the buccal mucosa or in the alveolus or anything, my CECT would do the job for me to tell me the size of it, the involvement of the bone, and how much of necrosis, everything. It will give me a picture. Okay, so you will preserve the MRI for the tongue lesions and lesions where you are suspecting bone marrow involvement or the nerve involvement. So that is where you will go for the MRI scan. The PET-CT, as sir rightly said, we don't use it as the primary modality. We keep it for in cases where you are doubtful. For example, you have a lesion which is more than 4 centimeters. It is going from one subside to the other. Say the person is having in the tongue, it is going to the oropharynx or to the hard palate. It means the tumor is pretty aggressive. When the tumors are pretty aggressive and in the later stages, say in the stage 4 or so, you will be suspecting probably this is not just retaining to the head and neck region, it may have gone to the other parts as well. That is when your PET-CT will come into the picture, because you don't want to do the surgery, morbid surgery on a patient who will be having like metastasis, where he will be having other palliative treatment, isn't it? So for such patients, you will have the PET-CT scan evaluation. Otherwise, CECT is more than enough in most of the cases, and MRI scan where you are suspecting bone marrow invasion or very light bone invasion and perineural invasions and muscular invasions. So it depends on the site of the lesion. Hope this is clear. Einass?
Yeah.
Yes, ma'am. Yes, ma'am.
Correct. See, this is how you have to talk. Talk as a, learn to talk like a consultant. You should be able to, kind of unravel the, just like you peel the onion, so that one layer after the other, it should come out nicely. Okay, carry on. Pathology.
Yes, sir. Further, you'll also use the mode of biopsy for establishing the diagnosis. Here, you will squamous cell carcinoma will account for about the 90 to 95% of the lesions, and here they can be categorized into well differentiated, moderately differentiated, and poorly differentiated tumors. And
one second,
yes, ma'am.
I just
Yes,
would
ma'am.
like to tell. So that will come to the histopathology more, like
Yes,
you are telling in terms of that. But from the clinical point of view or clinician point of view, how would you take a biopsy comes into picture first, correct? So would you take a brush biopsy or an incisional biopsy or just an FNAC in few cases? So how would you take the biopsy comes into picture before we jump into the pathological types of tumors. Okay, so I would say the last 2 points you have given here, that is histopathology and then the sentinel lymph node biopsy, this all comes under pathological, where you can divide it into 2 branches telling like clinical procedures like biopsies and then OT procedures like your node biopsy. Okay, and the histopathological features you are telling, it comes on a later stage. Okay, so can you tell me all the types of biopsy methods do you know of, what we do?
Ma'am, first there's incisional biopsy, wherein the suspicious, usually that is done under local anesthesia. And when the lesion is sufficiently large, and that is when you go ahead with that. Then excisional biopsy, you do it like the entire lesion along with a margin of, like you also remove a healthy tissue margin as well. And that is for lesions which are less than 1 centimeter. Then further there's like punch biopsy and brush biopsy as well. Punch biopsy is basically like if the area is more posterior. The lesion is more over the posterior aspect, and that will help you in getting a full thickness sample. Like punch biopsy will help in that, and brush biopsy, ma'am, mainly it is basically used for screening more, ma'am, in comparison to other available biopsies.
Yes.
And yes, ma'am.
So yeah, these are few types of biopsies which you can do. So if there is a lesion deep inside the tongue, you cannot get a biopsy. That is when you will go for actually ultrasound guided FNAC also we have done. Okay, you can go for that. We know that FNAC has lesser sensitivity, but that is one of the types as well to get initial picture of what the lesion is. Okay, so these are the types of biopsies and histopathological samples we will be giving it to them. Yeah, continue, Einass.
Yes, ma'am. Yes, ma'am. And a sentinel lymph node biopsy, this is an intraoperative procedure which we usually do, and it is usually performed at the same time as that of when we are doing the surgical resection of the tumor. And it will
just a
yes,
minute, ma.
yes,
Ravi, when will you consider doing sentinel node biopsy? What is the main principle?
Sir, if lymph nodes are not palpable, sir.
When the lymph nodes are not palpably enlarged.
Sir.
So that is the only time when you do sentinel node
Sentinel
biopsy.
node. Yes, sir.
If they are already enlarged, and you would have either the CT or ultrasound will tell you whether the nodes are possibly malignant or whether they are just reactive.
Yes, sir.
Okay.
yes. So we use sentinel lymph node biopsy, and this will also help us in deciding whether we should go ahead with an elective neck dissection, or whether we can put the patient under surveillance and observation if needed. Yes, sir.
Einass, I would now request Dr. Jyothsna to just highlight, because see, breast and some of the other areas, sentinel node biopsy is well established. I want Jyothsna to let us know what is the exact role of sentinel node biopsy now, and how has it progressed.
Sir, again, sentinel lymph node biopsy is still not in the mainstream diagnosis of the oral cavity cancer, because we already, as it is a oral cavity cancer, and we can see the primary site and we can know where the lesion is, and we can easily get the biopsy from it. So depends on it, sir. If it is a squamous cell carcinoma, without saying, according to the NCCN guidelines, anyways, it is the neck node dissection till 1 to 3 in the early stages, and beyond that in later stages.
Yeah.
So still that is being followed for the main things. However, few studies have come with the sentinel node biopsy or excision. That is enough, Anta. The follow-up studies have different results as such, sir. Few studies say they have got a good result, and few studies say there are recurrences. So that is still not yet into the mainstream yet, sir.
Correct. I think that is what I wanted you to say, so that students don't go there and say sentinel node biopsy first.
Yes.
Because people will get annoyed. So I think what you guys have to understand is, I think the basic minimum that is now advocated is for example, all the oral cavity malignancies is this, wide excision or major reconstruction, depending on the size and extent on the of the tumor. And in addition, a supraomohyoid neck dissection is a standard process. So I think sentinel node biopsy can maybe used selectively in certain patients, so that I think you should not go into that controversy. I think that we should leave it to the super specialist. Maybe MCH, oral malignancies and things, head and neck. Maybe those people can look at those controversies. You have to standard answer should be wide excision or hemiglossectomy or hemimandibulectomy, and all those things. In addition, a supraomohyoid neck dissection is the standard of care as of now. Then depending on the number of nodes on the CT and clinical and all that, then you you can extend that to modified radical neck dissection, or all these other types of neck dissection, depending on the site of the tumor and the aggressiveness of the tumor and the presence of lymph nodes and other things. Okay, carry on.
Yes, sir. Further going to the staging, the AJCC has the edition of AJCC has given the oral cavity staging. Herein, the important point to remember is that in oral cavity, the depth of invasion is significant in the process of staging, wherein they usually T1 is less than 5 mm, T2 is more than less than 10 mm, and T3 is more than 10 mm. Then furthermore, in the lymph node status, it looks into the
One
extra
second,
node.
Einass.
Yes, ma'am.
You
Yes,
have
ma'am.
mentioned that DOA is there, and you have an asterisk marks below which tells DOA is depth of invasion, not tumor thickness, correct? Can you tell me what these two things are? How different they are? What is tumor thickness? What is depth of invasion?
Ma'am, tumor thickness is the visible, like the tumor which is there, ma'am. But the depth of invasion is the layer to which it is extending, ma'am.
Not really. So when you put up a slide, it's better to go through what all is there in that, so that you'll be ready to answer the questions, correct?
Yes, ma'am.
So coming to what exactly this is, anybody else, Nikita, Praveen, anyone of you know what is depth of
Ma'am,
invasion and tumor thickness?
usually tumor thickness will be measured from the surface of the lesion to the extent where it has invased, but depth of invasion starts from the basement membrane, ma'am.
Correct. That is the right answer. Correct. So this is the depth of invasion from the basement of the epithelium to what extent the lesion has invaded. That is your depth of invasion. Whereas your tumor thickness is DOI plus the tumor which has risen over the surface as well. So it is a complete tumor thickness. So we are more interested in the DOI. Okay. So how do you know the DOI, Einass? You have just you are still in the diagnosis stage. You have not excised the tumor as such. How do you know DOI to stage it? And first of all, why do we stage the tumors, Einass?
Ma'am, depending on that, you'll based on staging, you can classify it into the first early stage cancers and late stage cancers, ma'am. And after that, depending on that, the treatment will vary, ma'am.
Correct. So it is for the prognosis per se. A patient comes to you telling listen, I have this much lesion, and on my examination I will tell so and so. So he will ask me, what is the prognosis of this? By doing the surgery, or by as such how it is. So it is important for your own decision of how you are going to manage the case, okay, and also the prognosis. So these are the two things which are important. And sir,
Nikita or Praveen, can you tell me, I think madam has covered the two most important reasons why you have to stage the disease. But can you tell me another very important reason why we have to stage the disease accurately?
So it also affects the neoadjuvant adjuvant therapies, sir.
No, management. She said, and then prognosis she has already said. So those two things are given. What is the other thing? What are we doing in our hospital, which many other people don't do?
Palliation, sir.
No, not we are.
No,
Why
no,
are we doing palliation? Not palliation. What are we doing? We do all this. We present our. What are we doing?
yeah. See, sir is telling in terms of in hospital. Exactly. Yes.
Research. See, basically, you have to compare apples with apples and not apples and oranges. So you have to, if you grade the disease correctly, if you stage the disease correctly, then you can compare your study with somebody else. If all of you are singing from the same hymn sheet, the AJCC classification, then you know whether tumors are behaving badly in India compared to Europe, for example, or America, all these things. So when you are doing research, when you compare studies from elsewhere, you can say whether our tumors are much more aggressive, or are we doing suboptimal surgery. All of these things can be comparable. So that is why you have to always stage the disease correctly, so that when you compare other studies, you will know where you stand. So that is another important cause, a reason. Carry on, Einass.
Yes, sir. Further, you also look at the regional lymph node involvement and the distant metastasis.
Just
Yes, sir.
go to the
Yes,
lymph
sir.
node. Tell us
Yes, sir.
what is N1, N2, N3. Important.
Okay, so N1 is when in a single ipsilateral lymph node, and it should be less than 3 centimeter, and furthermore, it's less than 3 centimeter in the greatest dimension, and it should also not have extra nodal invasion extensions. Then further, N2 will be again in the single lymph node, 3 less than 3 centimeter, and this can have extranodal extension. And the other criteria is that it can be ranging between 3 to 6 centimeter and not having extranodal extension. And N2B comes when there is multiple ipsilateral lymph nodes, but they are not measuring more than 6 centimeter, and there is no extranodal extension seen. And N2C is when there is a bilateral lymph node involvement, and again less than 6 centimeter in the diameter, and with the absent extranodal extension. N3 is further again divided into N3A and N3B, wherein N3A is more than 6 centimeter in size, and N3B is ipsilateral lymph node, more than again here it can be more than 3 centimeter with the extranodal extension present. Multiple ipsilateral or bilateral lymph nodes with extranodal extension, or if there is a contralateral lymph node which is present with the extranodal extension. Then you have the distant metastasis, with M0 being no metastasis and M1 being distant metastasis. After depending on the TNM stages, they are the staging is done into 1, 2, 3, and 4 group. And based on the staging, we will further decide upon the treatment modality for the malignancies, oral cavity malignancy, like stage 1 and stage 2 being coming into the early stages, and stage 3 and stage 4 being in the late stage of oral cavity cancers.
So just to simplify this, Einass, so if at
yes,
all
sir.
if there is a node present, okay, if at all
Yes,
if
ma'am.
there is a node present with just T1, T2, T3 or something, it usually generally comes off to stage 3, okay?
Correct.
And if at all if there is a metastasis present, without doubt it will go to stage 4.
Yes, ma'am.
Correct. So in the stage 4 itself, you also can consider the tumor size. Okay, if it is like,
Yes, ma'am.
yeah, more than 4 centimeters and there is like extension to different subsides of it, then you can easily tell it is a stage 4A or 4B depending on that. So it is a simplification of the whole thing. You cannot like mug all these things, right? So as
Yes,
a rule, you just remember that like T lesion size, and if the nodes are present or not, and if the nodes are present on one side or on the both the sides, the size of the node, and if metastasis is present. If you can just like remember these things, you can easily stage them. Okay. And I asked you, how would you know that DOI? So whenever we are
How will you
taking,
know? Yeah. Nikita or Praveen, how will you know preoperatively depth of invasion?
Sir, we can evaluate it by imaging modalities like ultrasound and MRI.
CT.
Can give an idea of depth of invasion.
Contrast and on CT. Didn't you hear Jyothsna just now say majority of oral malignancies, the investigation of choice is the contrast enhanced CT, which will give you the depth of invasion.
Yes, sir.
Okay.
Also, another thing is like whenever we are taking a biopsy, we won't be just taking the tumor, sir. We will be taking a normal tissue underneath as well.
Also, yeah.
That also will give us a
Give you the depth
clue.
of invasion. Yeah.
Yes, sir. Continue, Einass.
Yes, ma'am. Going to the management part. Firstly, oral cavity cancer will involve the following sites, which includes the lip, the lower alveolar ridge, the upper alveolar ridge, the retromolar trigone, hard palate, the anterior 2/3 of the tongue, floor of the mouth, and buccal mucosa. Firstly, the early cancer stages, that is stage 1 and stage 2 cancer, stages of cancer, we can, the treatment modalities will be in the form of surgery or in the form of radiation therapy.
Okay.
And
Once I would like to disrupt you here. So again, like treatment for any cancer in the body, not just oral cavity, not just this one, you would always come up with 3 things. One is the tumor factors, one is the patient factors, and one is the doctor factors. Correct? So that is pretty important. Like we think it is not, but it actually is. Like it depends on what the stage of the disease is. Okay. And if the accessibility is there, if the patient has come with a lesion in the oral cavity, but he also has trismus, you don't have the accessibility. How would you plan that? Do you have enough facilities in your hospital to do that? That comes for your doctor or hospital facilities. And coming to the patient factors, what is the age of the patient? Like what is his expectation out of the treatment? What is his ECOG status? Can he afford the treatment? Okay, does he have caretakers to take care of him? So these are all the patient factors. Coming to the doctor factors, like say if I'm there, like if say if Aditya sir was not here, can I do the reconstruction? Not much, correct? So these are all few things for the reconstruction and everything. The doctor or hospital factors will come into picture. So any tumor we are talking about, we always must keep these things in mind and then only plan the management. Okay. Now, yeah, you can continue with the stage 1. Have you heard of NCCN guidelines? I am sure you all must be reading for other tumors too, correct? So
yes.
we all follow that too. NCCN guidelines is the main thing which you follow because it keeps updating depending on so many studies world over. Okay. So just try to read that. But anyways, you continue with what you're presenting today.
Does anyone know who J.P. Shah is? He is the doyen of head and neck oncology. Jatin P. Shah. He's in Memorial Sloan Kettering. He is one of those outstanding surgeons who put oral malignancies on the world map, and he's one of the leading oral malignancy surgeon. And we proudly we can say he's an Indian. So he's in Memorial Sloan Kettering. We should know about this. Jatin Shah has written a lot of monograms and textbooks on head and neck malignancies.
Yes.
Jyothsna, anything to add?
No, sir. Yes, sir. That is true. We have studied his books as well. His books on oral malignancy and the treatment part, especially his the picture, the illustrations of his surgical pictures are very good to understand, and the concepts are simple and nice to understand. I have the book in my iPad. I can share it to them like when they are free.
Carry on.
Yes, sir. So, you have surgery and radiation therapy as the treatment options. Usually we prefer going with initial surgery and surgical resection should be considered as long as there is no significant morbidity or functional impairment which is seen. And radiation therapy, herein we use both external beam radiation therapy and brachytherapy as well. There's a on the basis of the dosage and schedule, the radiation therapy can also be used in the treatment of the stage 1 and stage 2 cancers. Firstly, going to the site-wise management, if the malignancy is present on the lip, if it is present on the lower lip, then it is more commonly to be basal cell carcinoma. And here we will like usually surgical excision is generally the preferred mode of management, and it is not usually lymph node metastasis is not usually seen with lower lip lesions, and that's why only the surgical excision of the tumor is sufficient. Whereas in upper lip, squamous cell carcinoma is more associated to be seen arising with the upper lip, and it has a relatively worse prognosis in comparison to the lower lip. They are more rapidly growing, they show ulceration sooner, and they even metastasize faster. Therefore, herein you will consider aggressive treatment aggressive treatment, which will again involve surgical resection with a and it will depend entirely upon the size of the lesion. Herein, you will have to focus on getting an optimal margin. Like more than 5 of a margin is generally recommended, but this also this is also associated with cosmetic and functional morbidity in terms of speech, the facial expression, and eating. So therefore, you have to consider reconstruction options as well. Like the defects which are involving less than 2/3 of the lips can be closed primarily, while whereas the defects which are involving more than that, you require reconstruction using your full thickness pedicled flaps should be used. The next being the lower alveolar ridge and the retromolar trigone. The retromolar trigone is basically the small mucosal space which is at the third molar of the mandible, extending posteriorly and cranially. It is continuous with the buccal mucosa and upper and lower gingiva. Even if it is an early stage cancer, these are known to have a high local recurrence rate because they are associated with like microscopic extensions to the mandible, and they also have a high chance of having lymph node metastasis. So surgical therapy will involve wide local excision, and if it is a small tumor, you can maybe use a transoral approach, and but most of the cases might require lip splitting, like a cheek flap for exposure, and in order to achieve tumor free margins, you might also require to do a marginal mandibulectomy in these cases. And again, one the low in coming to the alveolar ridge, the status of the teeth plays a very important role in the treatment of cancers, which if it is involving at the alveolar ridge. Like edentulous patients, these patients will have a very porous cortical bone, and therefore they will be at a very high risk of mandibular invasion. So in these cases, they should be treated with a segmental resection of the bone. Segmental resection of the bone. Whereas if the patient has they have a relatively better dentition status, then in those cases you can the direct tumor invasion to the medullary space of the bone will be less. In those cases, the extent of resection can be less. Further, this is seen in case of lower alveolar ridge, and in upper alveolar ridge and hard palate, here both surgery and radiotherapy are offer equal, they are equally good, but surgery is preferred because radiation is associated with a lot of side effects, which would be in the form of osteonecrosis of the maxilla, or they can also have they can also develop conditions like xerostomia. So that's why surgical resection is preferred here. And for buccal mucosa, like buccal mucosa, you usually go ahead, exposure can be difficult if it is an early stage, then you can try transoral approach, but it is difficult to resect with clear margins in an en bloc fashion. And there is also a very short distance between the buccal mucosa, which will allow an early invasion to the deeper structures or to the skin of the anterior cheek. So here we should consider removing the skin also and reconstructing both the inner and outer cheek surfaces. And but here the chances of disfigurement and morbidity associated with these procedures is very significant. And the buccal mucosal surface is reconstructed, and we should ensure that there is adequate soft tissue coverage, because in the absence of this, there will be severe trismus is a complication in this. And radial forearm flap is usually considered for the reconstruction process. In term for oral tongue and the floor of the mouth, oral tongue, partial glossectomy with negative margins can be done, which will preserve the sweet speech and swallowing for in most cases of stage 1 and stage 2. And the floor of the mouth, here, this is because of difficulty in inspection and because of this limited space, it is difficult, and these tumors are generally locally invasive. There is a very high risk of neck node metastasis. So here you can try transoral excision, and depending upon the size of defect, if it is a small to medium sized defect, you can close it primarily. And large defects will require using a graft, which could be a radial forearm flap, or you can also use a submental skin flap as well.
Okay.
Yes.
Einass, so you did cover a lot of points and they're all relevant, I understand, but a little confusing for somebody who is listening to it for the first time, especially the beginners. Okay, just to simplify whatever you have said, I'll just tell you in an easier manner. Okay, so basically you have stages or in terms of tumor, right? T1, T2, T3, T4, right? So generally for the T1, T2 tumors, usually we will go for single modality treatment. Okay, the first the slide which you had put, either surgery or the radiotherapy, right? So that is what you would do.
Yes, ma'am.
Few people do go for the radiotherapy, like brachytherapy in case of lip cancers. Again, rare in our clinical settings, because we believe surgery is the best modality for the oral cancers. Okay, so and also as you mentioned, there are a lot of morbidities involved with the radiotherapy. Not that it is less in surgery, but it always has better options to cover it up, like reconstruction. Okay, so always when you're planning a surgery, you will think of what am I doing for the primary, what am I doing for the neck, and how do I reconstruct it. So more than that, you can say we have 3 R's: resection, reconstruction, and just not that, we have to also think about the rehabilitation, because any tumor or any loss in the tissue and the difference in the anatomy overall after the treatment is going to affect them in speech and swallow as well. So we have to have rehabilitation also in the mind, correct? So in the T1, T2 lesion, usually you will do resection perorally, correct? You don't have to go, like it is going to be less than 2 or 2 centimeters. So you will just go and excise the lesion. Even though they say 5 mm is more than enough for the margin, we go for 1 centimeter because pathologically it may be closer margin, correct? So clinically you will aim for 1 centimeter margin during the resection. Okay, so neck, I hope you're covering it later. So again, in the reconstruction part, we'll think whether I'm going to take a regional flap. Okay, am I going to take the submental, or am I going to take the sublabial or the greater palatine? So a few things which we will see if we can cover it up in the nearby premises itself. If not, we will go for the regional or the distant flaps. Okay, so that is the reconstruction. In the T3, T4, generally, as the tumors are pretty big and they would be involving more than one subsite, we will go for the oral or lip split or the midline split. Okay, or the mandibulotomy also sometimes. Okay, so these are the approaches where you will go and resect the tumor again with 1 centimeter margin. Neck, again, I'm waiting for you to tell me how do you decide on ipsilateral or the bilateral or the extent of the neck dissection. Coming to the reconstruction in the T3, T4, generally they'll require regional or the distant flap. Again, in our clinical settings, what I and Dr. Aditya sir do is like we go for the distant flaps for better cosmetic and functionality as well. Okay, mostly we will go for free fibular flap or ALT flaps for the better reconstruction. So this is on a general note, like without confusing. Okay, now you please go on to the neck.
Yes, ma'am. Like this is an image for showing the lymph node levels, where level 1A, level 1B, that being the submental, submandibular, then the level 2A, the upper internal jugular, middle and low jugular nodes. Level 5 being the posterior triangle of nodes, and level 6 being the central compartment nodes. Level 7 is the superior mediastinal lymph node. Again, for the management of the neck it is again based on the primary tumor site. In if the lower lip is involved and the patient is in like stage 1 or stage 2, you can go ahead with observation rather than elective neck dissection. So if there is a superficial like lower lip cancer and your depth of invasion is less than 3 mm, you can either go for observation, or you can also consider going ahead with a sentinel lymph node biopsy. And the sentinel lymph node biopsy is preferred because lymphatics from the lip will drain to both sides of the neck. Uh, uh, if it is a T2 or like a larger lower lip cancer, then elective neck dissection is preferred in comparison to observation or sentinel lymph node biopsy. And here you should suprahyoid dissection. Herein you at least include level 1A, level 1B should at least be included before dissection. And if you are doing like upper lip, if
No,
the
I'm sorry. You
yes,
just
ma'am.
said above supraomahyoid. Yeah.
Yes, ma'am.
What is that levels? Is it just 1A and 1B?
Ma'am, it is 1, 2, 3, and 4 as well. Sometimes people include 4 and sometimes they don't, ma'am. Like level 1 to 3 is definitive.
No, yeah. So you call
Yes, ma'am.
supraomahyoid as 1 to 3. If you are involving
Yes, ma'am.
core, then you mention it as 1 to 4. You don't call it as supraomahyoid. Okay. So
Yes, ma'am.
yeah, you just include 1 to 3. So how do you decide, like, for which tumors do you do 1 to 3? For which tumors do you go for 1 to 4? So on
Ma'am,
a general note, you don't have to go to the primary this like lip, lower alveolar or something. On a general note, in the oral cavity lesions, generally, if you feel the tumor is greater than like 2 centimeters and also is more than 2 centimeters, and if they have told you that the DOI is more than 3 or 4 mm, you generally go for the elective neck dissection. Okay.
yes, ma'am.
Okay. So in that you will
yes,
be doing 1 to 3. Okay.
Yes, ma'am. Yes, ma'am.
So yeah, this dividing it might confuse for people. Do you have near the slide where you can explain like on a general like oral cavity management? No.
No, ma'am.
Then
This is what, like that.
You continue. If I can, I'll add the points in the end. Continue.
Yes, ma'am. Yes, ma'am. In upper lip, if in case of upper lip being the primary tumor site, you go ahead with elective neck dissection because they are generally very aggressive in nature. Then if the lower alveolar ridge or retromolar trigon is involved, here elective neck dissection is the choice. In like level 1 to 3, supra omohyoid neck dissection will be done because this is associated with a high incidence of occult nodal metastasis. If the upper alveolar ridge and the hard palate is involved, in these cases, again, you prefer getting an elective neck dissection done, especially if the staging is T2 or greater than T2. because these are the incidence of occult metastasis is again high in these cases. Further, if the buccal mucosa is involved, here also the treatment of choice is elective neck dissection, because the facial lymph nodes present here near the mandible are at a high risk of metastasis, and therefore you should consider elective neck dissection. The oral tongue and floor of the mouth, here you determine based on the tumor size, the DOI and the proximity to the midline. So basically, if you look at the tumor size, whether it is more than 3 mm and whether it is present in the midline or it is lateralized. Based on that, if the DOI is more than 3 mm, then you can consider bilateral neck node dissection, or if it is and close to the midline, or a sentinel lymph node biopsy. If it is more than 3 mm and tumor is lateralized, here the choice is unilateral elective neck node dissection. If the tumor is less than 3 mm in the midline, sentinel lymph node biopsy is the choice. The other alternative is doing a bilateral neck dissection. And if the tumor is again for less than 3 mm, whether it is midline or lateralized, it's the same. But in case of lateralized, the first choice can be sentinel lymph node biopsy, and the other option being unilateral neck dissection.
This is what I was talking about. So if you
Yes.
must know when you would be doing bilateral and when you would be doing unilateral. Again, as I was telling earlier, SLNB is still under study. So at present, the clinical practice, we would directly go for the other options, which is like unilateral or the bilateral elective dissection. Continue, Einass.
Yes, ma'am. Then going to stage 3 and stage 4 cancer, again your management will depend upon whether the disease is resectable, borderline function unresectable, or technically unresectable disease. If it is a resectable disease, you can consider a surgical technique through transoral approach, or a combination of transoral and transcervical approach. And again, we should make an attempt to ensure that you get a negative resection margins. And if at all there are positive margins, then adjuvant radiotherapy or chemo radiotherapy is indicated. Further, if there is a borderline resectable or functionally unresectable disease, in these cases, if the patient has a good performance status, you can consider giving them 3 cycles of doxycycline, cisplatin, and 5-fluorouracil, like a form of neoadjuvant systemic therapy, and after which surgery and radiotherapy or chemoradiation, if indicated, can be administered. And in cases of unresectable diseases, radiotherapy or chemoradiation are usually indicated in if the case is inoperable. These includes cases where there is the carotid artery encasement, or the vertebral involvement, or the brain invasion as well.
Correct.
Yes. Then again, like management based on site.
You mentioned that, isn't it?
Yes, ma'am. Stage 3 and 4,
Ah.
it's on the same lines, ma'am.
How many slides more are there, ma?
So, only a brief about the adjuvant therapy and chemotherapy, sir.
Continue with that.
Only 2 more.
Jyothsna,
Yes, sir.
just quickly, can you tell us about the role of neoadjuvant chemoradiation in patients with oral malignancy? Is there any role for it, or
Yes, sir, definitely. So when we have seen clinically for tongue malignancies, which has invasion into the floor of the mouth, base of the tongue, where it has gone beyond the oral cavity. As she mentioned in the previous slide, like borderline, like unresectable. So it is not exactly into the carotid space or the base of the skull, but into the places where the resection is very morbid. In such cases, we try to downstage the disease by giving neoadjuvant therapy, sir. So mostly for the tongue and floor of the mouth cases where the invasion is pretty aggressive, in such cases, and where we feel, if at all, if we do the resection, the morbidity is going to be high in spite of reconstruction. In such cases, we usually give a neoadjuvant therapy, then we go for the resection. Yes, sir.
Okay. Right, carry on, ma.
Yes, sir. For lip, you prefer definitive radiotherapy because in order to maintain the functionality and it is cosmetically preferable. And if the floor of the mouth is involved, in that case, again, like the lower alveolar ridge retromolar trigone, here you will try for surgical resection to achieve the sort of achieve the negative margins, and followed by adjuvant radiotherapy with concurrent chemotherapy can also be administered. In case of the upper alveolar ridge and hard palate being involved, in these cases, you first give radiotherapy, and even resection is done, in which case you can reconstruction with using either like an obturator or a microvascular free flap can be considered. For the buccal mucosa, they have a high tendency for regional recurrence. In this case, again, transoral approach is difficult. So you try for definitive radiotherapy, and if try attempting for a surgery, if at all the cosmesis and the functionality is not hindered, because in these cases, with this, there is a very high risk of severe irreversible trismus. Then further going to the radiotherapy aspect, radiotherapy is usually indicated in advanced tumor stages like T3, T4, where if you get at all get positive resection margins, tumor extension is present through the lymph node, perineural invasion or lymphovascular space invasion is also, if at all that is present, then in those cases you will consider giving adjuvant radiotherapy. Herein, you will
Two more points I would like to add, Einass. One is extranodal extension of the tumor in the neck. If we feel some residual tumor is there in the neck, and also where we have treated the oral cavity lesion but not addressed the neck, there also we'll be giving adjuvant radiotherapy.
Yes. So usually in the absence of any healing issues or any other medical contraindications, you start adjuvant radiotherapy within 6 weeks of surgery, and it should ideally be completed within 100 days or less from the date of the surgery. And the dosage usually varies. With T3 to T4, you usually administer 56 to 60 days of the is the dosage to the tumor bed, which is recommended. And if there are positive margins or extra capsular extension present, then a 6 gray boost can be given in 3 fractions for a total of 66 grays dosage. And the neck is usually included in the adjuvant radiotherapy. The only conditions where we can consider not including is when it is established that there is a pathologically negative node. And again, like the schedule, usually you give this 54 to 66 grays in daily fractions. You will give over 5 to 7 weeks is how it will be administered. And the radiation therapy techniques will include, it can either be given in the form of the external beam radiotherapy, or it can also be given in the form of brachytherapy. The chemotherapy regimens will involve giving drugs like cisplatin, carboplatin. Cisplatin being administered in a dosage of around 40 milligram per meter square weekly. And if at all there is a lot of platinum related toxicity or renal impairment, hyponatremia, peripheral neuropathy, in these cases you can consider switching to carboplatin, which is 50 milligram per meter square twice weekly, rather than giving cisplatin. And in other regimens, you have monoclonal antibodies like cetuximab, which can be used, and docetaxel can also be used in conjunction with the monoclonal antibody as a form of chemotherapy. That's all, ma'am.
Yeah, very good. Like one more point, that is immunotherapy also is into play nowadays. In case where we have palliative, the person is not fit enough for the surgery or the radiation as well. So we can all, or in the recurrences in stage 4 diseases, we can also use immunotherapy. I'm sure Sarup sir would be a right person to tell. But pembrolizumab, cetuximab, and these are few drugs which they will be using. Okay, that is just for the completion of the whole management.
Okay.
Yes.
I think, Einass, you've done an excellent job. I think you've understood the subject well, and you detailed the thing. I think it was a good class. Students, any one of you can please comment, and then finally, Jyotsna.
I feel she has done a good job too, sir. There is good briefing on it, and I feel she has covered all the points which are required. Yes, sir.
Students, anybody? Volunteer? Tanya?
It's a very nice class, sir, in detail about everything. She's covered almost everything. Sir.
Yeah. I think I would thank Jyotsna for timely intervention and clarification of very important points and simplification of the management protocol. Thank you very much. I think
Yeah,
it was
thank you so much, sir. Thank you, sir. Thank you for
thank
this,
you.
sir. Like I miss into the teaching things, and I'm more than grateful for you to inviting me for such things. I'll be happy to help the students, sir. And also,
Yeah,
sir,
sure.
I would like all of them to go through the NCCN guidelines once, sir. There is an app which can be downloaded in both iOS and Android. They can go through that for all the tumors, not just the head and neck.
Yeah.
Okay, sir. Thank you. Thank you.
Good night.
Good night.
Thank you.